Hello everyone, this is Dr. Meenakshi Gupta. Today I am going to take another topic of pharmacology, that is drug acting on renin-angiotensin system or inhibitor of RAAS. Now important is why we want to inhibit this RAAS system. Because we all know RAAS, it is a system which helps in the regulation of blood pressure, blood volume and electrolyte balance. Then why we want to inhibit this system? Further, we also know we have a two type of RAS. One is circulating and another one is a local. So there is a detailed video on the RAS. Link will be given in the description box. If you haven't watched that video, you can go and watch that. Here I will just be a quick revision of this circulating and local RAS, so that you will understand why we have to inhibit this RAS or why we need this group of drug. So here it is a circulating RAS. So you can see with the circulating RAS, what happens whenever there is a fall in blood pressure or fall in plasma volume, then what will happen? The renin that is released from the GG cell, and this renin, it is going to convert this globulin angiotensinogen into angiotensin 1, and this angiotensin 1, it is converted into angiotensin 2 with the help of enzyme, that is angiotensin converting enzyme. And this angiotensin 2, it is going to act on angiotensin angiotensin 2 type 1 receptor or AT1 receptor, which are present at various sites: blood vessels, heart, adrenal medulla, adrenal cortex, and even in the brain. So by acting on AT receptor, which are present at all these sites, just see in the blood vessel what it does. In the blood vessel, it is going to cause a generalized vasoconstriction. So by that, it is going to increase the blood pressure. Then another way is it is also going to act on the adrenal medulla. So it is going to cause a release of both epinephrine and norepinephrine. And you know they cause a vasoconstriction, and again there is a rise in blood pressure. So the system was stimulated, there was a fall in blood pressure. By activating this system, there is rise in blood pressure. Then another way is how it is going to increase the rise in blood pressure. This norepinephrine, they are going to stimulate this autonomic ganglion. Then norepinephrine released, that is from the adrenergic neurons, and there is increase in blood pressure. It also act on adrenal cortex. This is very important action and causes the release of aldosterone, which is going to act on distal convoluted tubule, and there is a sodium reabsorption, and along with that water is also reabsorbed, and there is a loss of potassium. Then it is also going to act on the posterior pituitary, where it is going to cause the release of ADH, and this, or it is going to increase the thirst, and this is going to act on collecting duct, and there will be water reabsorption. So all these, they are going to increase the blood pressure. On the heart, it is going to increase the force of contraction, and on chronic action, it is going to cause a hypertrophy, hyperplasia, and there is increase intracellular matrix. And this drug, it is going to increase the sympathetic outflow or sympathetic action by acting both centrally as well as on peripheral. Now, this system, the switch on is whenever there is a fall in blood pressure. Whenever the person BP, it falls below 120, systolic blood pressure, it is below 120, and diastolic is below 80. Then this system, it gets activated, and person is going to restore. And once the person achieve this normal, एक बार उसका अगर normal आ जाता है, once the person gets this normal blood pressure, then what will happen? This system, there will be switch off of this system. Now what will happen to this? This angiotensin 2, it is degraded into angiotensin 3 and angiotensin 4. And all these with the help of aminopeptidases. This angiotensin 2, it is converted into angiotensin 3 and 4 by the aminopeptidases, and which is going to further form inactive fragments with the help of angiotensinogens. That's it. So whenever there is fall in blood pressure, what will happen? This system, it is activated and person is going to restore the normal blood pressure, and this angiotensin 2, it is degraded into inactive product and or inactive fragments. So this system, there is a switch on and off. Whenever fall in blood pressure, it gets activated, and this is how this system it works. But what happens, sometime the person is having a normal blood pressure, ठीक है, इतना है उसका blood pressure, person is having a normal blood pressure, but there is increased renin in the circulation. ठीक है, पर्सन का ब्लड प्रेशर क्या है? ब्लड प्रेशर पर्सन का नॉर्मल है, बट renin that is there in the circulation. If renin is there, then what will happen? This renin, it is going to produce the angiotensin 2, and which is going to act on AT1 receptor, which are present at all the various sites. Now what will happen? There will be increased blood pressure. Now the person blood pressure, it is more than, उसका ज़्यादा है, more than normal, 120/80, इससे ज़्यादा होगा. Now person will be hypertensive. So in most of the renovascular hypertension, we see this increased level of renin, plasma renin activity or plasma renin level, that is more in renovascular hypertension. Okay. Then in essential hypertension also, the evidences are found in essential hypertension also in 20% of the patient, the renin level that is more, and even the level of this angiotensinogen, that is also more. So whenever, that means whenever the person blood pressure is more or when the person is hypertensive, that time we have to give this group of drug. So this is one indication. That is the time when we have to inhibit this system. Okay. So this is a one indication why we need this group of drug. Now coming to the local. Now local RAAS, with this, what is there? There is a extrinsic and intrinsic. I am not going to take a detail. You can watch my previous video. So with the intrinsic, which is present within the cell, that is heart, blood vessel, kidney, adrenals. So they are going to generate angiotensin 2 within the cell. Now what will happen? In the local RS or local RAS में, the renin, it is synthesized as a larger peptide, as a pre-prorenin. And this pre-prorenin, it is converted into pre-prorenin and or prorenin and renin. Sorry, here it is not pre-renin. This pre-prorenin, it is converted into prorenin and renin. Now, effect of this prorenin or renin, it is further angiotensin 2 dependent or angiotensin 2 independent. So this local RAS, what it does, it is going to, whether it is a angiotensin 2 dependent or angiotensin 2 independent, it is going to trigger the intracellular signaling by causing the activation of MAP kinase, then JAK-STAT pathway, tyrosine protein kinase pathway, plasminogen activator inhibitor 1, and all these, they are going to enhance the expression of proto-oncogens, transcription factor and growth factor. And this results into what? Cell growth will be there, collagen deposition will be there, fibrosis will be there, apoptosis will be there, myocardial remodeling or vascular muscle remodeling or hypertrophy, then nephropathy and retinopathy. That means the overactivity, what this slide shows, the overactivity of local RAS, this, it leads to all this. Okay, so this remodeling of the myocardium or myocardial hypertrophy or myocardial remodeling, that is very common in CHF. Fibrosis, okay, in the post MI patient, so that is also very important. Then retinopathy and nephropathy, that means whenever the patient is having all these things, we have to give the drug to inhibit this pathway. So the first was a hypertension. Second one is if the person is having myocardial hypertrophy and remodeling, just like in CHF. So this is another indication. Then in MI patient or any patient with a cardiovascular risk, we can use this drug prophylactically. Then of course in diabetic patient, they are more prone for nephropathy and retinopathy. So diabetic, nephropathy and retinopathy. And even in non-diabetic also, non-diabetic nephropathy also, it shows its beneficial effect than retinopathy. So these are the indication when we have to give the drug which can act by inhibiting this pathway. In the next slide you can see clearly. So hypertension, just now I've told hypertension is if there is a myocardial hypertrophy and remodeling. So because in a diabetic patient the ratio of the circulating prorenin and renin level, that is also elevated. So we have to give in diabetic nephropathy and retinopathy. Another one is a scleroderma crisis, and in this also there is a rise in blood pressure plus renal damage or renal issues. They are mainly because of the increased level of angiotensin 2. So in this condition also we have to give the drug. Now how we can inhibit this pathway? At what all level we can inhibit this pathway? Let's look at the first, the renin. So we can, so this renin release, it is stimulated by activation of the beta 1 receptor. Okay, so we can give, this is the number one. So number one is by giving a beta blocker, we can inhibit the renin release. Then second one is this. The second one is a renin inhibitor. Okay. So what this renin inhibitor they do, they are going to inhibit the action of renin. Remember one thing, this beta blocker, they are going to inhibit the release of the renin from the GG cell. But once the renin, it comes into the circulation, then renin inhibitor, they are not going to allow that renin to act on the angiotensinogen. So this is the difference. So one drug, it is going to inhibit the renin release, and this is going to inhibit the activity of the renin, this renin inhibitor. Now, what are the other steps? Then number 3, at this level, we can give the ACE inhibitor. So by giving the ACE inhibitor or angiotensin converting enzyme inhibitor, we can inhibit the conversion of angiotensin 1 to angiotensin 2. This step, it is inhibited. Okay. So then once the angiotensin 2 it comes, it is going to act on angiotensin 1 receptor. So we can block this also. This is number 4. Number 4 is angiotensin receptor blockers. Then another one is we can give the aldosterone inhibitor or aldosterone antagonist. Okay. So this is the how we can inhibit this pathway at various sites. 1, 2, 3 and 4. So first one is a beta blocker, or we can give any drug which act by blocking the central sympathetic outflow. So centrally sympatholytic, they can be also used here to block this effect, to block this renin release. Then second one is a renin inhibitor. Third one is a ACE inhibitor or angiotensin converting enzyme inhibitor or angiotensin receptor blocker, and then aldosterone antagonist. So in today's video, I will be mainly focusing on renin inhibitor, ACE inhibitor and angiotensin receptor blocker. So ACE inhibitors, that is captopril. What all comes under ACE inhibitor or angiotensin converting enzyme inhibitor? This slide I have taken it from KD Tripathi. So captopril, then enalapril, lisinopril, perindopril, ramipril, fosinopril, quinapril and tarendolpril. Then angiotensin receptor blocker. We have losartan, candesartan, valsartan, telmisartan, irbesartan and olmesartan. And direct renin inhibitor, this drug it is available. Aliskiren. Okay. Another one is which is not used, ramipril. So what is common here in this drug? All they end with the pril. All this drug they end with the sartan, and this drug it end with this. Okay. Now coming to the first one, ACE inhibitor or this captopril. This is the prototype drug or the first drug of ACE inhibitor which was introduced in 1977. So whenever we talk about any individual drug, so what all headings it should be covered, this any drug. So you should give a little bit of introduction. आपको उसकी इंट्रोडक्शन पता होनी चाहिए, कौन से ग्रुप की है ड्रग. देन द मोस्ट इम्पॉर्टेंट इज मैकेनिज्म ऑफ एक्शन. उस ड्रग का आपको मैकेनिज्म ऑफ एक्शन और एनी एडिशनल एक्शन, जैसे फार्माकोलॉजिकल एक्शन इफ इट कम्स, यू कैन राइट दैट ऑल्सो. फार्माकोलॉजिकल एक्शन. Then you can write about the pharmacokinetic, where we can use it, therapeutic uses. Then adverse effect, contraindication or any drug interaction if you know. Okay, this is you must try to cover any individual drug under these important heading or any important point. So this captopril, if it comes, it is a ACE inhibitor. It is a angiotensin converting enzyme inhibitor. Now how this drug it is going to act? So you all know. So angiotensin converting enzyme, this is going to inhibit angiotensin 1 conversion into angiotensin 2. So this is how angiotensin, or you can say the captopril, it is going to act. So angiotensin 2, it won't be able to act on AT1 receptor. So there will be no rising, no vasoconstriction. So all the action of AT1, they will be inhibited. This is going to act on AT1 receptor. So all the action of this angiotensin 2, they are reversed. But what happens? I'll show you the first diagram, this one only. So this is how ACE inhibitor they are going to act. But if you are going to give this ACE inhibitor, now there is no vasoconstriction. आपने जब ये दिया ACE inhibitor, if you look at this, there will be no vasoconstriction. Then what will happen? The feedback. What is the feedback? It is going to increase this renin because there is a now fall in blood pressure. With ACE inhibitor, there is fall in blood pressure. And this fall in blood pressure, what it is going to do? It is going to cause the increased renin release. Once this is increased, then what will happen? There is more angiotensin 1. Angiotensin 1 आपका क्या होगा? It will be more. It will be more. Now, angiotensin 1, it is not converted into angiotensin 2, but angiotensin 1 that is there. Now, this angiotensin 1, it will be converted into angiotensin 1 to 7, and this has got the vasodilator property. Okay, so angiotensin 1, it will be converted into angiotensin. The pathway it is diverted now because angiotensin 1 it is not will not be converted into angiotensin 2. Now where it will go? It will move towards the angiotensin 1 to 7. So which has got the vasodilator property. Now another important point about the ACE. So this ACE or angiotensin, this drug, captopril, it is going to inhibit the angiotensin converting enzyme. Now angiotensin converting enzyme, it is a non-specific enzyme. This enzyme, it is a non-specific. So it is not only going to inhibit this ACE, angiotensin converting enzyme, it is a non-specific. It is not only going to act here, but it also acts here also. Okay? It also causes the or inactivation of bradykinin, substance P. It is going to cause the inactivation of this also. Now what will happen? If we are going to give the ACE inhibitor, now we are going to inhibit this. Okay? आप इसको inhibit कर रहे हैं. We are going to okay? Now we are inhibiting this by giving the drug. It is not only going to inhibit this, but it is also going to inhibit this pathway. That means bradykinin and substance P, it won't be degraded. So there will be accumulation of not only this, but also accumulation of bradykinin and substance P. This is going to cause the cough. ठीक है, इससे क्या होगा पेशेंट को? दिस इज द साइड इफेक्ट ऑफ द एंजियोटेंसिन कन्वर्टिंग एंजाइम inhibitor. Now what else? So the effect of this drug, it is more effective if the persons that is depleted with the sodium. In a sodium depleted person, the hypotensive effect is more as compared to if the person is taking the sodium in the diet. Now what are all others? So this is the mechanism of action. Now what are its important action of this group of drug? Now this group of drug, it is going to cause dilatation. Now if there is no vasoconstriction, that means it is going to cause a dilatation. So dilatation of, so vessel space का क्या? The dilatation of the artery and arterioles is more as compared to the capacitance vessels. ठीक है, veins की कम है. So postural hypotension, that is not a problem with this drug until unless if the person is taking any diuretic or any other thing. ठीक है, तो arterioles that is dilated. So there is the fall in blood pressure. Both systolic blood pressure will fall and diastolic. Both they will fall, but there is no sympathetic stimulation. So we can use this drug safely if the person is suffering with the ischemic heart disease. उसमें भी हम ये वाली drug we can use. Then the renal perfusion. Coronary perfusion and cerebral perfusion, they will be unaffected, though there is a dilatation, but there will be no effect on this. Nothing will happen to cardiac output. Okay, if we go on the heart, on the cardiac output, cardiac reflexes, nothing will happen. Now, the therapeutic, so this is about the mechanism of action. This I will be taking later on. Now, therapeutic uses of this group of drug, where we can use it. Okay. So already I have told the number one is hypertension. There's a long list of antihypertensive drug. Now, what are the advantage of this group of the drug if we are using it as an antihypertension? See, remember one thing, as if you want to remember antihypertensive drug, the most important are A, B, C, D. You can remember it this way. A stand for ACE inhibitor or angiotensin receptor blocker. B for the beta blocker. C for the calcium channel blocker, and D for the diuretic. So you can remember it this way. So this group of drug, ACE inhibitor and ARB, they are the first line drug in most of the renovascular hypertensive patient, and even they control essential hypertension patient also, either alone or we can give it in a combination. And then in diabetic hypertensive patient, there also we prefer. What are the advantages of this group of drug? So number one, it does not cause the postural hypotension. No electrolyte imbalance. Just like if we are using the diuretic, there is no electrolyte imbalance that is seen. No hypokalemia. No secondary. This is all seen with the diuretic. Hyperaldosteronism. No hyperuricemia. Okay, this is the advantages of this group of the drug. What else? Suppose if we are putting the patient on this beta blocker we cannot give to the asthmatic patient. This we can give in the diabetic patient, asthmatic patient. Okay, and no effect on the lipid profile. Can safely give. No withdrawal. Hypertension. Okay, already I have told it is not going to affect renal, cerebral or coronary circulation. If the person suffering with the peripheral vascular diseases, there also we can put the patient on this. It is not going to affect the quality of the life of the person. Okay, so minimal affection on the quality of life of the individual. It is also going to reduce the cardiac morbidity and mortality. So these are the advantages of this group of drug over the others. So we can use this group as an antihypertensive in all these situations. Okay. Now coming to the second use, we can use it for the CHF. So in the CHF, they are going to retard the left. So what happens in CHF? The heart is not able to pump. Okay, so mainly it is not able to pump, so organs, they won't be getting the supply. So it is going to retard the left ventricular dysfunction. Okay, and improve survival in all the grades of CHF patient. कोई भी है, whatever grade is there in CHF patient. Now how it does? So first one is, it is, if you are going to put the patient on ACE inhibitor or ARB or ACE inhibitor, they are going to cause, CHF patient में क्या करता है, this ACE inhibitor, it is going to cause both arteriolar dilatation and venous dilatation. So what will happen with this? Both the afterload and preload is decreased. Okay? And especially this afterload. If it is decreased, then what will happen? The renal perfusion is improved. If this is improved, then what will happen? Diuresis will happen, and whatever sodium and water retention is there, retained, it is with this diuresis. So this is the one advantage. Another one is, if you have seen this local RAAS, what it is going to cause? It is going to cause the ventricular hypertrophy and remodeling. So by inhibiting this, what it is going to cause? It is going to inhibit myocardial and vascular hypertrophy, remodeling, and apoptosis of the myocardium, and also inhibit the fibrosis. Okay? So it is going to, what is, inhibit the progression of the disease, progression of the CHF. That's why improve the survival. Improve the survival in the patient with the CHF. Now, next one is 1122 line. That is more than enough. You must know why we are using it for this. Now, in myocardial infarction, what it is going to inhibit the recurrent myocardial infarction, and it is also MI, and to prevent the need for cardiac angioplasty, and it has to be given within 24 hours and should use for 6 weeks. Then prophylactically it is used in high risk patient. Okay, suppose in post MI patient, okay, or any patient with a high risk, so it is going to improve the endothelial function. Now another use is, we are going to use it for the diabetic nephropathy. So even if it is a diabetic nephropathy or a non-diabetic nephropathy, दोनों में ही this is going to help. It is going to delay the end stage renal failure. Now how it is going to delay the end stage renal failure. Okay. So what it does, it is going to reduce the glomerular filtration pressure. By reducing this, what it is going to cause, it is going to decrease the or reduce the proteinuria or albumin urea. So this is how it gives a protective action. So then another one is, it is also going to increase the creatinine clearance. So reduce the dialysis. Then in diabetic patient, it is going to decrease the micro and macrovascular complication of the diabetes. It is going to reduce the intracellular matrix. This is another. Then also it is going to inhibit the reduce the retinopathy. This is another use separate. Diabetic, this one ACE inhibitor, it also reduces the diabetic retinopathy. What is the another use of this group of drug? So another use is, it is also used for the scleroderma, because here there's a rise in blood pressure and renal damage that is mainly associated with the rise in angiotensin 2. So this is the therapeutic uses of angiotensin converting enzyme inhibitor. Now coming to the pharmacokinetic or the individual drug, captopril, enalapril, lisinopril. So all these drugs, they are almost same. So only difference is in a little bit on pharmacokinetic feature. So here I have already highlighted the two drugs, captopril and lisinopril. They are the only which are active drug. Rest of the drug, they are a prodrug. So they get activated the body. After the activation, what they become? Enalaprelate, fosinoprelate, perindoprelate. So you can compare all the pharmacokinetic features of this group of drug. If you see the duration of action, almost all of them, they are 24 hours except this captopril. So it is a fast acting with the short duration of action in comparison to the other drug. So it is a, but bioavailability of the this one, it is maximum, the oral route. So bioavailability of lisinopril, the slow and incomplete absorption of the lisinopril, that is the, if you compare this lisinopril with the captopril, you can see the potency. So this is the least potent, and you can see here the potency, the amount of the drug. If it is less the drug, it is more potent. So another important difference is with the fosinopril. Fosinopril, its nature is, this is the only one which is available as a fosinate. And another important is the elimination is both renal as well as hepatic. Then ramipril, the important is, this is the one which is mainly going to inhibit the, very effective in inhibiting the local RAAS. So this is important pharmacokinetic feature. This also I have taken it from the KD Tripathi. Now next one is an important adverse effect with this group of drug. So these are the therapeutic uses, already I have told in detail. So adverse effect of the captopril. So you can remember it with the, it's captopril. C is cough, that is seen in 10 to 16% of the patient within 1 to 8 weeks or within 2 months. So this is because of with the captopril, there is a accumulation of the bradykinin and substance. Mainly it is a bradykinin. Then angioneurotic edema. This is a rare angioneurotic edema, and rashes and urticaria. If you go for the allergy, this is more common. So A for the angioneurotic edema. Then if we are going to use it for the bilateral renal artery stenosis, it can cause, this is another, you can use A for the acute renal failure. So if we are going to use it for the bilateral renal artery stenosis, so this is an important contraindication. So contraindication of the captopril one is a bilateral renal artery stenosis. Then P stands for the proteinuria, which is rare. T for the taste disturbances, this is mainly with the captopril. O for the other side effect like headache, dizziness, nausea, bowel upset. P for the level of potassium, that is increased. All R already I have told. I for the itch, and L for the low blood pressure. So partial hypotension, that is only if the person is treated with the diuretic. So these are the adverse effect of the captopril. Now coming to the contraindication. Now what are the important contraindication with this drug? It is completely contraindicated in pregnancy. It is a fetopathic, causes the growth retardation, and even it can cause the fetal death also. Then it is also in, already I have told, bilateral renal artery stenosis. It can cause the acute renal failure. Then if the person is having hyperkalemia, okay, so increased potassium, so there also it is contraindicated. It should not be given with the other drug which is going to increase the level of the potassium. Okay, so potassium sparing diuretic, it should not be. This is important. Drug interaction also. So these are the two important contraindication. It's during the pregnancy, and a bilateral renal artery stenosis, it should not be given. So it's important drug interaction. So one is already I have told, not to be given with the potassium sparing diuretic, whether NSAIDs or any drug which is going to increase the level of the potassium. Then another drug interaction is with the diuretics. Diuretic, that is plus. This is also hypotensive. Effect of this ACE inhibitor, it is going to increase, because diuresis, they are also going to cause a loss of sodium and water. So hypertension action will be increased. Then this is going to inhibit the action, because it is going to cause a sodium and water retention. So this is not to be given. And potassium, like potassium sparing diuretic, spironolactone, that is going to cause the hyperkalemia. So these are the important drug interaction. Now coming to the second group of the drug. So this is all about the ACE inhibitor. Now coming to the angiotensin receptor blocker, or losartan, candesartan, valsartan, telmisartan, irbesartan, and olmesartan. All of them, they are angiotensin receptor blocker. They are the competitive antagonist of this receptor. So if I take up the losartan, it has got 10,000 times more affinity for AT1 as compared to the AT2 receptor. So they are going to compete. So competitive antagonist of this AT1 receptor. So they are going to block this receptor, so that what will happen? The angiotensin 2 won't be able to act on the AT1 receptor. What are the basic differences? So you can see here the mechanism of action of ARB. So they are going to act on this. They are going to block the action of all this. Okay, so angiotensin 81 receptor, whatever all there is there, it is going to block the action of all. So by that it is going to have all the therapeutic uses, like we can use it as an antihypertensive. Then for the CHF, so little bit differences they are there with this angiotensin receptor blocker in comparison to the ACE inhibitor. So you can see the what are the differences it is going to show. Can we give both together, or which one is to be preferred over the other? So you can see the how the ARB they differ from the ACE inhibitor. So number one is ARB, the ACE inhibitor. So because ACE, angiotensin converting enzyme, this is the enzyme which is required for the degradation. You can see here. So this is the enzyme which causes the degradation of this. If we are going to, if drug is acting here, then what will happen? This will be degraded because we are not blocking here. This. Okay. So this will be degraded, and what will happen? The side effect of angiotensin receptor blocker, the cough and all that won't be seen. So this is a number one difference. Number two is more complete inhibition of this. See, this angiotensin 2, it is also formed by another pathway, non-ACE. Okay? So angiotensin 1 to angiotensin 2. This is, we know it is formed by ACE, but there are non-ACE pathway that is also going to form, like proteases. Here you can see the proteases. This is the enzyme which converts this angiotensin 1 into angiotensin 2. So non-ACE pathway, they also generate angiotensin 2, which can cause the vasoconstriction and other effect. But if we are going to block the receptor, then what will happen? There will be complete inhibition of this pathway. Okay, so this is the number two difference. Number three is there is no increase in the level of this one angiotensin. ये वाला आपका level नहीं बढ़ेगा. This level it is not increased. Okay, because now this pathway it is like this. Otherwise, if we are going to block here, then what will happen? Angiotensin 1, instead of making this angiotensin 2, it will be diverted. If we have given this angiotensin converting enzyme, if I inhibit this by giving any drug, okay? If I inhibit this, then what will happen? The angiotensin 1, it won't be converted into angiotensin 2. So where it will go? The pathway is diverted. It is going to form angiotensin 7. But if I give a blocker of the receptor, then this diversion won't be there. Okay. So now another one is in my previous video, because this system is what is there, once the this angiotensin 2, it is going to act on the receptor. It is going to act on various receptor 81. Now this 81 receptor, they are also present on JG cell. Okay, on the JG cell of the kidney, 81 receptor, they are there. So this pathway, there's a the feedback inhibition of this pathway is there's a short loop and there is a long pathway is whenever there is a rise in blood pressure. एक बार blood pressure जब normal आ जाता है, then what will happen? This angiotensin 2, it is converted into, it is degraded into all these. Okay, and another one is the short loop is this angiotensin 2, it acts by 81 receptor which is present on the GG cell. So it is going to act on here and there is no release of further renin. So if we are going to give this 81 receptor blocker ARB, so what will happen? This short loop, ये आपका mechanism, this will be inhibited. If this is inhibited, then what will happen? This renin will be there, angiotensin 1, angiotensin 2, that will be there. So there is a increased level of all these. So there will be blockage of this short loop feedback mechanism. So more angiotensin 2 will be produced, which is going to act where? Which is going to act on 82 receptor, angiotensin 2 receptor. So can we give both the together? Definitely, if we are going to, there is no any benefit, advantages of using both of these drugs together, because if we are going to give both together, it can cause hyperkalemia, hypotension and renal impairment. Okay? So these are the disadvantages if we are going to like combine both, and advantages are So you can see all these differences. By looking at this, you can make out whether we have to give or not. Now where we are going to use this group of drug, ठीक है, इसको किस में यूज करते हैं? हाइपरटेंशन. सो हाइपरटेंशन में definitely we prefer ARB because if the person is having any cough or angioedema, that is not seen with this as a hypertension. Then in a CHF, in the CHF, what they say, because they have seen all these like valsartan, candesartan, they are showing inconsistent result. So what, because of that, presently we prefer ACE inhibitor over ARB. So when this person is showing any adverse effect or any side effect, then we can switch over to this. Moreover, this with this way ACE inhibitor, there is angiotensin 1 to 7, there will be prostacyclin and NO. They are also there which has got the vasodilator action, and it is beneficial especially in the CHF patient. So we are keeping this one as a reserve drug, ARB, in the CHF patient. Then in diabetic nephropathy, again we can use any, but चाहे आप ये दे दो, चाहे आप anyone will do. Now coming to the third group of drug, that is renin. Okay. Before this, just tell a few differentiating points among all these. The most important is like losartan and valsartan, they are almost same. In many of them, they are excreted in the pharmacokinetic. We give it by oral route, excreted in the bile. Okay. Now important is this telmisartan. Telmisartan, it has also got PPAR gamma activity. So it is going to reverse the insulin resistance. Okay. So this is the, and this has got the highest affinity. Right. Now coming to the next, aliskiren. So how aliskiren, renin inhibitor or aliskiren? It's a non-peptide. We give it by oral route. इससे क्या पता, peptide we won't be able to give it, so we give it by oral route. Now what this aliskiren it does, it is a renin inhibitor, so it is going to bind on the catalytic side. This is, suppose if this is a renin. Okay. Now what happens, this aliskiren, it will come and bind over here. Now what will happen, if aliskiren will come and bind over here, this site it is not available for the angiotensinogen. It won't get access to this site. Now if it is not going to get the access to this site, then what will happen? Angiotensinogen won't be able to convert into angiotensin 1, and there will be no formation of angiotensin 2. The whole RAAS pathway that is disrupted. Here important is the renin level, the plasma renin level, that is increased. Okay? But renin activity, plasma renin activity, that is decrease, because it is going to inhibit this renin activity. It won't allow renin to act. So plasma renin activity that is decreased, but renin level that is increased. Remember this thing. So this is important. So where we are going to use this group of the drug, this is as used as an alternative antihypertensive. So uses are almost same, where we can use angiotensin converting enzyme inhibitor, where we can use angiotensin receptor blocker. Same we can use this also. This is used as a alternative antihypertensive drug. Okay. Then we give it by oral route. Already I have told you. But this drug, it is palmed out by the P glycoprotein. Half-life, it is more than 24 hours and it is mainly excreted in the feces. Very well tolerated. This is also contraindicated in a pregnancy, and few GIT side effects they are there, like loose motion pain, abdomen, headache, dizziness. They are there with this group of drug. Okay, that's all about this topic. So in today's video I have discussed about the angiotensin converting enzyme inhibitor, angiotensin receptor blocker and renin inhibitor. Now what are the important questions for this from this topic? So usually the MBBS students, they usually get explain the RAAS, okay, or what is RAAS and what are the drugs acting on RAAS. When you get this question, you have to write all the 5 drugs: beta blocker, centrally acting sympatholytic, which are going to both this group, they inhibit the renin release. Then renin inhibitor, they are going to inhibit the action of the renin. Then ACE inhibitor, then angiotensin receptor blocker, and the 5th one is we have a aldosterone antagonist. Write the mechanism of action. Therapeutic uses ADR, contraindication of ACE inhibitor or captopril. Same way for the angiotensin receptor blocker. Then adverse effect of the captopril. Remember with the captopril name itself, from this you can derive all the side effects. Okay. Then why ACE inhibitor? They are contraindicated in bilateral renal artery stenosis because it can cause the acute renal failure. Okay. That's all about today's video. If you like my video, then please share it and subscribe my channel.